say welcome. Zev Nakamura, MD, addressing cognitive dysfunction in patients with cancer.
Great to be here. Thank you.
Absolutely. We are thrilled to have you, Dr. Nakamura. Let me tell folks a little bit about you. From what we know, Zev Nakamura, MD, a psychiatrist and clinical researcher with advanced training in psycho-oncology and a career focus to improve cognitive outcomes in patients with cancer. His goal for this line of research is to rigorously evaluate objectively measured and patient-oriented outcomes of cognition, understand how other psychosocial and biological variables impact cognition, and test pharmacological interventions to prevent or treat the cognitive consequences of cancer and cancer care. Related to his interest in cognitive outcomes in cancer patients, he has served as the lead investigator on 2 clinical trials. His research has also examined methods, bereavement characteristics in widowed fathers who have lost a spouse due to cancer, end-of-life experiences of mothers with advanced cancer, and depression and anxiety in women with breast cancer. Dr. Nakamura, outside of your professional bio, what's one other thing we should know about you today?
Yeah, I wanted to share that in January of 2020, I joined my a bowling league for the first time. And our team was making a strong move in the playoffs when it was put on pause by COVID, only to be resumed at some time in the future.
Well, what a great sport. And we hope you can get back to that soon. Well, we speaking of sports, we'll make a segue into softball here and say that we're going to give you a softball question. Cancer-related cognitive dysfunction, CRCD, can cause impairments in attention and memory for cancer patients and survivors, and that's a true or false. I don't know if there's an analogy to softball in bowling, Dr. Nakamura.
Not that I know of.
Okay, well, we'll use softball for that then. And while you're thinking about that, this activity has been planned and implemented under the sole supervision of the course directors in association with the UNC Office of Continuing Professional Development. William Wood, MD, MPH, and CPD staff have no relevant financial relationships with commercial interests as defined by the ACCME. Zev Nakamura, MD, has no financial relationships with commercial interests as defined by the ACCME. And if you haven't anonymously responded to that question, now's your chance. I think they're doing okay, Dr. Nakamura. What would you say?
I think that looks great and look forward to talking more about this in the rest of the hour.
Great. All right. Well, that takes us to your part. So addressing cognitive dysfunction in patients with cancer. Take it away and just let me know when to advance those slides.
Again, great to be here, and thanks everyone for listening in. Today, we are going to talk about cognitive issues that come up in folks with cancer who are also undergoing treatment. And so I'll start by just providing some general background, then transition to some causes for how this occurs, talk a little bit about how to screen and diagnose cognitive problems in patients with cancer, talk about what types of treatments are currently available, and then I'll close with a few slides on a study that we're conducting here at UNC, looking at a medication called memantine to prevent cognitive decline in patients with breast cancer. Next slide. The learning objectives closely follow the outline. We'll start, I hope that folks can identify causes of cancer-related cognitive dysfunction, that they can describe the impact that these cognitive problems have on patients' everyday lives, and then finally recognize what available treatments there are for these cognitive issues. Next slide. So in terms of kind of the background on what this is all about, so starting in the 1970s, researchers were starting to observe that patients who are undergoing chemotherapy were experiencing decline in their cognitive function. It's actually first reported on in the American Journal of Psychiatry in 1980. By the 1990s, the term chemo-brain was coined to refer to this cognitive decline that seemed to be associated with chemotherapy. In the early 2000s, we started to get more information about how these symptoms evolve over time. And then really in the last 15 to 20 years, things have shifted to an understanding that this is really not something that is specifically a consequence of chemotherapy, but rather a more broader consequence of cancer and other cancer treatments. And as a result, folks now more often refer to this as either cancer-related cognitive dysfunction, or CRCD, cancer-related cognitive impairment, or CRCI, which is the term that I'll probably use the most in this lecture. And then interestingly, there was a recent article that came out where they sort of recoined this tumor brain, again with the goal of emphasizing that this is a problem that starts with the cancer itself. Next slide. In terms of understanding how common this is, the research suggests that close to a third of folks will begin demonstrating problems with their cognition before starting on their primary line of therapy. There may be several reasons for this, and we'll talk about those later. But the proportion of affected folks certainly goes up once treatment starts. And it's believed that as many as 75% of people will experience at least some sort of cognitive issue during treatment. And then a subset will continue to experience symptoms as well as demonstrate impairment on objective testing years following the end of their treatment for cancer. Next slide. So cognitive and cognition certainly are kind of broad terms that may be difficult to really put your finger on, and that's certainly the case for patients. And so in terms of understanding what types of things I'm referring to when I say cognitive or cognition, these are problems with memory, and most often patients will use the language that they're having problems with their short-term memory, but it also includes problems with concentration or focus, as well as folks' ability to plan and organize things, which is often captured by executive function. It's hard for folks to learn new material. In the vast majority of cases, these cognitive issues are relatively subtle, and many of you have probably heard patients describe this as a brain fog. So rather than a massive impairment or massive deficit, there's sort of a cloudiness that folks will notice that make it harder to do a number of things or to do as well on tests in these specific areas that I've outlined. But there really is a small portion of people who experience more dramatic problems such that they're not able to return to their previous level of function. And in general, these symptoms will gradually improve as folks get away from treatment, but the exact way that these symptoms change over time varies from person to person. Next slide. So this is our first poll everywhere question, and I hope that this kind of sets up a little bit more detailed discussion about the effects of CRCI on other aspects of life. But this is basically asking, well, what are the consequences or the impacts of cancer-related cognitive impairment? Can this affect long-term cognition? Can it affect ability for folks to return to work, impact their physical function, their overall quality of life, or all of the above? And Tim, if you could just let me know when you think enough responses have come in, and I can reveal the answer and move on.
Absolutely. So I would say if folks can take just about 5 more seconds. I don't see the dials moving much. So Dr. Nakamura, how are they doing?
They're doing great. You know, I'll admit that many of these poll everywhere questions also are softballs, but I hope that they'll kind of get folks thinking about some things that maybe they didn't realize before. And so it looks like, you know, a small portion of folks thought that, you know, CRCI may be related to long-term cognitive impairment, overall quality of life, but does also affect problems returning to work and physical function. So the correct answer is E, all of the above. Next slide. So what has the research shown in terms of the impact of CRCI? So it's certainly associated with worse mental health, like depression and anxiety and overall emotional and social well-being. There is actually a really large body of research about the impacts of CRCI on occupational outcomes. So either people not being able to return to work or not being able to function at the fullest capacity they were prior to their cancer and cancer treatment. We have done a few studies here that have demonstrated this really tight link between folks' cognitive abilities or cognitive function and their physical function or functional status. And then there seems to be kind of newer research that's showing that cognitive issues in cancer patients actually is associated with increased mortality. I'll show you an example of that on the next slide. Additionally, I'll say that patients who are having cognitive problems are less likely to be offered more aggressive treatments for their cancer, and the impact that this has on providers' decision-making is more so than older age or poor overall functional status, and that's really interesting. Additionally, and maybe this is intuitive, folks who are having cognitive issues have worse compliance with their medications, and surveys have revealed that cognitive issues are one of the most feared consequences of cancer and its treatment among cancer survivors. Next slide. So there's a lot going on in these figures, but I'll walk you kind of through it piece by piece. So this comes from a study of older, meaning 75 years or older, patients with leukemia, myeloma, or lymphoma, and they had cognitive testing done. And the test in the A panel is a test of memory, and the test in the B panel is of executive function. As I mentioned before, executive function basically captures how folks organize and plan things. And so what we see looking in the top left figure is that folks with worse cognitive function as defined by their performance on a memory test lived statistically shorter amount of time than those without impairments on that memory test. And now if we transition to B, that test of executive function, though the differences between those who performed normally on the test of executive function and those who performed in the impaired range did not reach statistical significance, you can see that it looks like those who were performing in the impaired range did worse. And then if you jump down to the bottom right figure of figure 2B, you see that if you look in the subset of patients with more aggressive cancers, that executive function testing performance also was associated with shorter survival. Next slide. Okay, so this is the next poll everywhere question. I hinted at some of this, but certainly not in detail. So what are the causes of cancer-related cognitive impairment? We've talked about chemotherapy as being kind of the first aspect of cancer treatment where folks had noticed a relationship. We have not yet talked about the effects of surgery or radiation or hormonal therapy. We'll look at those more closely in the coming slides, but here we'll get a sense of what folks either are thinking or have heard about from their prior experience.
All right. Well, this looks great. Are you ready to go ahead and move on?
Yeah, so the correct answer is E, but those who answered A, it's not totally understandable given the information that's out there thus far. So we'll talk in more detail here in the coming slides. Next slide. So first, I'll start by describing some overarching causes of cognitive impairment in cancer patients without relating them to specific aspects of treatment. So one potential mechanism is direct toxicity, so that the treatment for cancer or the cancer itself may somehow directly be affecting the brain and its function. The next mechanism, which we'll talk about a lot in different places in this talk, is neuroinflammation. So basically the experience of these patients having high levels of inflammation throughout the body, including in the brain, and that leading to a number of downstream effects, including oxidative stress and DNA damage. And again, we'll talk about that more later. And then interestingly, there's growing research about genetic factors that either increase folks' risk for cancer-related cognitive impairment or protects them from experiencing impairment during cancer and cancer treatment. And one that I'll highlight in particular is this ApoE4 allele. So this allele type is a very well-established risk factor for Alzheimer's disease. And interestingly, it also appears to be a risk factor for cognitive problems related to cancer and cancer treatment. Next slide. So I'd like to take a few moments to talk about these images and what they're showing, because I think it captures and sums up nicely a number of different take-homes about cancer-related cognitive impairment and what it is. So these images come from twins. They're 60-year-old women, and twin A is one who was diagnosed with cancer and has undergone chemotherapy, and her twin in B is healthy, doesn't have cancer, and has not received any, as you'd expect, treatments for cancer. The red in this figure refers to the amount of work that the brain is doing. So these are taken from functional MRIs, and you can see that for both twins, as you move from the leftmost panel to the rightmost panel, you see more red. So basically the brain is working harder from left to right, and that's because these images are taken while these twins are completing increasingly difficult cognitive tests. So the first thing we see here is twin A, the one with cancer, is working much harder on the same tests. Two interesting things is you look at the results of the test, the twin in A did do worse on the test, but really only by a little bit. But then if you asked her how her cognition was, she described it as substantially worse than her twin, even though she did only a little bit worse on the testing. So to me, what I take from this is that cancer-related cognitive impairment captures both actual impairment on testing, but also someone's subjective experience of how their cognition is working, and that both the tested performance and the subjective performance can be measured or correlated with other sorts of findings such as imaging. Next slide. So in that last slide, we were focused on functional brain MRI, but we also see some other common findings, such as folks with cancer who have these cognitive problems in general have less gray matter. Their white matter is not as well connected. And then there are many studies that show kind of more specific findings in different brain regions, but these aren't as consistent as these kind of first three things that I mentioned in terms of the gray matter volume, white matter connectivity, and changes in brain activation. Next slide. I'll pause there actually for a moment because I see that a question is coming in. And the question was a clarification about the slide. Was the twin with cancer getting active chemo, or was she a long-term survivor of cancer? To answer that question truthfully, I'll admit that it's been a while since I have reviewed that. I believe it's someone who was currently undergoing treatment. But I think to get more at the heart of the question, similar findings have been observed in long-term cancer survivors. And in fact, the majority of the research of this area of cancer-related cognitive impairment is in long-term cancer survivors, as opposed to people who are currently undergoing treatment, are pre-treatment, or have recently completed treatment. Thanks for your question. So next slide again. Yep, good, perfect. The next sort of overarching causal factor, we'll say, for cancer-related cognitive impairment is inflammation. And so we know that both in cancer and many medical conditions, folks experience elevated levels of inflammation, and that's certainly common in neurocognitive disorders too, like Alzheimer's disease. Interestingly, when folks with cancer undergo treatment, for example, chemotherapy, their levels of inflammation increase, and though they go down as they get further out from treatment, they remain elevated relative to healthy folks, and that the degree of elevation of inflammatory markers is correlated with both self-reported and objective cognitive performance, similar to what we saw with the functional imaging. And I will acknowledge that there are a lot of different inflammatory markers, and the story can get very, very complex, but these clearest relationships are with inflammatory markers TNF-alpha, which I'll talk about later in the context of my study, IL-6, and IL-1 beta. Another person asked, I'm currently undergoing chemotherapy. How soon do you start to see these cognitive changes? And so what I would say is, first, that everyone's experience is quite different from one another, that the most common experience is that folks will notice cognitive problems, the most severe cognitive problems, if they're going to have them during treatment, and that's going to be relatively noticeable early on. So just in the same way that folks may feel fatigued when they're undergoing treatment, they may also notice that brain fog. Again, everyone's experience is different, but usually it will be most commonly noticed and most severe during treatment and early on in treatment, as opposed to a delayed effect. But we'll talk about some exceptions to that as we get into some of the different aspects of treatment. Thanks for your question. The next kind of relationship I wanted to talk about was between cancer treatment, and aging. So we talked about the inflammation piece and how inflammation relates with oxidative stress and DNA damage. We also see that folks are undergoing cancer treatment, and anyone as they get older, experiencing a shortening of an aspect of their chromosomes called telomeres, and also they have an increased proportion of their cells that enter a senescent state, which refers to when cells are no longer growing or dividing. There's some really, really interesting work that was started here at UNC of a biomarker of cellular senescence, P16, which showed that during chemotherapy, breast cancer patients experienced changes in their P16 levels that were correlated with 10 years of chronologic or actual aging. And similar results have been observed in both humans and in animals. Next slide. So that has led to a couple hypotheses, neither of which has been fully validated. And one is that folks who have cancer and go through certain aspects of treatment, they take an initial cognitive hit. But as we all experience small declines in our cognition as we get older, so do cancer patients, and it's at the same rate, but that they take that initial hit. An alternative hypothesis, or the accelerated aging hypothesis, is that cancer patients or cancer survivors experience an initial hit and then over time decline more rapidly than those who never had cancer. But the truth is we don't have enough good long-term studies to really clarify this. Another question that came in was about changes in those P16 levels over time. And to my knowledge, we don't have that information yet to understand, do the P16 levels go back in the direction that more closely corresponds with folks' actual chronologic age. So now we'll go through sort of the different pieces of this puzzle and try to tease out, the ways in which these different either the cancer itself or different aspects of treatment may impact cognition, knowing some of these broader mechanisms that we talked about in the previous slides. So beginning with the cancer or the tumor itself. So in general, the mechanism that's believed to be driving this is through immune system dysfunction, which is very closely tied with what I've talked about with inflammation and changes in inflammatory markers. The other thing that I'll say here, and we'll say again later, is that folks with cancer often do not feel physically well, that they feel fatigued, they can experience emotional changes like depression, and that all of those things can impact both how folks do on cognitive tests and also how they feel that their cognitive function is performing. The other thing that I'll mention here is that if folks experience cancer in their brain, in the central nervous system, that there's an additional layer here in the ways that this impacts cognition. So if you have something in the brain, that can lead to swelling, increased intracranial pressure, actually move brain tissue and affect blood supply and cause brain damage in a way that's different than cancers in other parts of the body. Next slide. So we've already talked a decent amount of chemotherapy, but I just want to add a couple things. So one is that in general, the vast majority of chemotherapies do not cross the blood-brain barrier, meaning they do not go from the blood across the blood-brain barrier into the brain. But research, mostly in the animals, has shown that cancer itself, as well as the inflammation that I've mentioned before, can increase the leakiness of the blood-brain barrier and make it possible for very, very small amounts of chemotherapy to cross into the brain. It's been shown, again, this is in animal studies, that those very small amounts can cause damage, and that may be one way that this is occurring. But more likely this is related to inflammation, including in the brain, that has effects on a number of different cell types in the central nervous system. Next slide. So not a lot is known about the effects of surgery, and I think much of that is a logistical one. Folks will often get surgery as a really early part of their treatment for their cancer, and so it's challenging often to capture the unique effects of surgery itself. But there's some research to suggest, for example, that mastectomy compared to lumpectomy may have greater adverse cognitive effects. And this may be related to increased pain with that sort of surgery, increased inflammation from a larger surgery, as well as the psychological effects of how your body has been affected, with removal of a part of your body. There may be certain vulnerable populations who may experience cognitive effects of anesthesia that's used during surgery. And then it should be noted that in the same way that a brain tumor can uniquely impair cognitive function, that surgery to remove a tumor affecting the central nervous system can actually, in some cases, improve cognitive ability. Next slide. In terms of radiation, there is radiation that's targeted directly at the brain or nearby areas, and that can lead to something called radiation necrosis. Someone earlier had asked about kind of the timing of the effects of chemotherapy. The effects of cognitive effects of radiation, if due to radiation necrosis, are delayed. So it's often not noticed by folks to weeks to months after they're done with their radiation, if that's the case. But radiation to areas outside of the head may also have adverse cognitive effects, and that's through many of the same mechanisms as has been described already for chemotherapy. Next slide. The impact of hormonal therapy, however, on cognition seems to be different, and that makes sense. So for example, we know that estrogen and testosterone support brain function, so it's not of great surprise that tamoxifen and aromatase inhibitors also are associated with cognitive difficulties, although those relationships have not been shown consistently across studies. And I will say that in general, the effects of hormone therapy on cognition are thought to be smaller or less severe than that of cytotoxic chemotherapy. We see similar relationships with androgen deprivation therapy for prostate cancer in terms of potential to lead to negative cognitive effects. Next slide. So now I'll transition to some of the newest agents and say up front that we know almost nothing about these in terms of their impacts on overall cognitive performance. So I'm sure most of the people in the audience have heard of immunotherapies or checkpoint inhibitors, and these have been rapidly expanding and critical part of cancer care. That theoretically there could be a concern in terms of how these would impact cognition. Both because they can lead to neuroinflammation, but also because they're often given in combination with other immunotherapies or other aspects of treatment. So you could imagine a sort of synergistic effect on cognitive impairment. In clinical trials looking at the efficacy of these treatments for cancer, there have been reports of cognitive issues, but really not a lot is known here, and particularly not a lot is known about more long-term effects. Related to that, there's a treatment called CAR T-cell therapy, which again, I'm sure many of you have heard of or are familiar with to different degrees. And CAR T-cell therapy can lead to a cytokine storm that's associated with encephalopathy or acute mental status changes in approximately 30% of patients receiving CAR T-cell therapy. But what we don't know is how those acute changes may lead to more long-term effects, or just separately from those acute changes if patients experience long-term cognitive effects from CAR T-cell therapy. Next slide. Similarly, for targeted therapies such as monoclonal antibodies, we really see mixed results depending on the specific targeted therapy that's being examined or the cancer that it's being studied in. And so really more research is needed to understand how these agents may affect cognition in patients with cancer. Next slide. So now I'll say again that there are many comorbidities that affect cognitive function. And some of the big ones are sleep disorders, mental or emotional problems like depression, anxiety, pain and pain medications, fatigue, anemia, and other medical conditions. And I mention this and try to emphasize it because not only are all these things extraordinarily common in folks who have cancer, but also many of them have better and more readily available treatments than we have for the cognitive effects themselves. So these are really critical to keep an eye out for and think about ways to optimize to see if you can get some movement in the right direction with folks who are experiencing cognitive problems. Next slide. So I think this is a really, great schematic to illustrate a lot of different elements of what goes into people's cognitive function. So on the left, these are the things that people bring into the clinic or their presentation in the hospital, things that probably can't be changed, like how old they are, their education, their genetics, as well as the cancer itself. And then we've talked a lot about how different treatments can affect cognition, and then started to acknowledge there that then there's all of these other comorbidities that really play a role. And I think this slide highlights both the potential that where we're not at yet, but the potential to understand folks' unique risks for having cognitive issues during cancer treatment, as well as the ability to intervene in a personalized way. Next slide. So now I'd like to just talk a little bit about measurement. So I've referred a number of times to self-report or patient-reported measures as well as objective testing. And I'll say problems are much more common than impairment on objective testing. And in people trying to understand this discrepancy, there has been one line of thought that, well, maybe self-report isn't really measuring cognitive ability, and instead it's capturing something else. Like if someone's feeling really depressed or anxious, maybe they're more likely to say that they're having cognitive problems, even if that's not the case. But there's also a line of thinking that maybe objective testing isn't sensitive enough, that putting someone in a room in a highly controlled testing environment is just not going to pick up on the issues that folks are going to notice day-to-day in much more complex, day-to-day environments. And then I think the other point that's worth making is even if objective testing is extremely valuable, is it really feasible for everyone, who has cancer, undergoing treatment for cancer, to get testing? Is there the expertise for that? Is that the right use of these patients' time? So I think that really reveals the dual importance of both patient report and objective testing. Next slide. I won't go through these in detail, but again, I just want to highlight that there's these self-report measures, that then when you get to objective testing, there's both screening instruments and then more in-depth neuropsychological assessment, and kind of what the different measures are for this, and that there's no one way that you should be screening or monitoring these cognitive problems, but rather a collection of pretty well, validated ways. Next slide. I think another thing to consider is, well, what might be appropriate based on your clinical setting? So I think self-report screeners could have a role, across the board, including in primary care settings or in oncology care. Whereas the objective screening instruments, though not challenging to learn how to administer and interpret, do require some training and certainly require a bit more time. And so this is more likely going to be something that you would want a psychiatrist like me or a psychologist or a neurologist to do. Occupational and speech therapists are also very, experienced in administering and interpreting objective screening instruments. And if you or a patient feel that neuropsychological assessment is warranted, which would be a 3-hour, dedicated detailed test that looks at all of these different cognitive domains, that would involve a referral to a highly trained neuropsychologist. Next slide. Okay, I think this is our last poll everywhere question, and it's the one that doesn't have an all of the above. This says, which of these does not have at least some evidence for the treatment of CRCI?
And while you're answering that question, I will say that as soon as we get done with this question, I'll go ahead and move on to the next space in Poll Everywhere, which is where you can submit your questions. So in about 60 seconds here, you'll be able to start going ahead and sharing your questions for Dr. Nakamura at the end. Dr. Nakamura, I know you still have a lot to cover, so maybe we should go ahead and let them know how they're doing.
That sounds good. People are considering a lot of different things here, and the majority are correct that Ginkgo biloba does not have at least some evidence, and we'll talk about that soon. Next slide. So here, I just want to outline, how I think of the categories of interventions that have been studied for CRCI. So these include behavioral interventions, physical activity, mind, body, and then medications. Next slide. One of the types of behavioral methods is cognitive training. And just to give you a sense of what this is usually in front of a computer and involves increasingly challenging cognitive tasks. There's this sort of exercising the brain in a similar way that you might exercise a muscle in another part of your body. So this occurs close to daily and over a number of weeks. That there's about 10 studies to support this, and like most interventions, it's primarily in early stage breast cancer survivors who are ways out from the main aspects of their treatment. Next slide. By contrast, cognitive rehabilitation does not involve that same sort of exercising of the brain function, but rather it helps patients increase their awareness of the types of cognitive deficits they're experiencing and how to work around them effectively. These strategies were first developed in traumatic brain injury and stroke populations and are generally weekly sessions with trained professionals. And there have been a similar number of studies and have been tested in both individual and group settings, in person and remotely. And another thing that we see across all these interventions is they generally do have better effects on patients' cognitive symptoms as opposed to their testing performance. Next slide. Physical activity is also very promising. It seems that physical activity can help reduce inflammation, that increases levels of a protein called BDNF, which is helpful for brain growth. Physical activity has also been shown to be of benefit in neurodegenerative disorders like Alzheimer's disease and slow age-related cognitive decline. And I've included some local resources here for physical therapy, including those that are more specific to patients or survivors of cancer. Next slide. There are a number of mind-body interventions that have been looked at, including meditation, mindfulness, and acupuncture. And I've highlighted here that there are local courses that are offered through both UNC Chapel Hill and Duke. There's a very well established online program through UCLA in California. There are also apps that help, that provide mindfulness, I think can be helpful to patients, and then also included some resources to find, get connected with acupuncture. Next slide. And then here's the scope of medications that have been looked at. And so even though there's not evidence for Ginkgo biloba, it has been studied, as were the erythropoietin stimulating agents, and we'll talk more about these in a moment. Since I saw that other question come in, those agents that are often, there are commercials for, have not been studied for cancer-related cognitive issues. Next slide. Similar amount of research for medications as with the behavioral techniques, but honestly, it's been less promising. So the only agents, too, I'll say that have been looked at in prevention, because we've highlighted that this interventions have mostly focused on cancer survivors after they've, started experiencing the impairment and often had it for multiple years, have been these three agents. And I'll just pause to highlight, Ginkgo biloba actually was studied in a very large, multi-site way, extremely rigorous, and most of the medications, other medications, that's not the case, but it was shown in this very large, well-done study to not be helpful. Next slide. So this will transition us now to me telling you just a little bit about our study here at UNC. Memantine to prevent cognitive decline in patients with breast cancer who are undergoing chemotherapy. Next slide. So a little bit more about memantine. So this is a pill that is taken by mouth that has decades now of safety data. It is only FDA approved for Alzheimer's disease, but it may be effective to improve cognition in several medical conditions. And the reason that I got interested in its use for addressing cognitive issues related to chemotherapy is, one, that it blocks the harmful inflammation in the brain that we've talked about already, and that I'll describe more on the next slide. Two, that there was a large study in patients receiving brain radiation where it seemed to prevent cognitive changes related to that aspect of cancer treatment. And three, there have actually been studies in animals that have shown that it prevented the adverse cognitive effects of chemotherapy in that setting. But we're the first to look at it for this purpose in human patients. Next slide. So as we've discussed, inflammatory cytokines are elevated in cancer, increased during chemotherapy, and seem to correlate with cognitive deficits. If you pull up the figure, I'll highlight that one of the best studied cytokines, click once, is TNF-alpha. And TNF-alpha increases the release of glutamate from a variety of cells in the central nervous system, which then act downstream on neurons to lead to increase of calcium production of reactive oxygen species, and ultimately neuronal cell death. And what's interesting about memantine, click once, is that it blocks one of the receptors that glutamate acts on, the NMDA receptor, and may prevent cell death that way. Next slide. So a little bit more about the study. Again, we're interested to see if it can prevent these cognitive changes. We give it to patients concurrent with their chemotherapy. It's a pill that's taken twice a day. Their cognitive abilities are tested, and we also ask patients to complete surveys about things like their depression, fatigue, sleep. There's other things that can impact cognition before they start treatment and about 4 weeks after treatment, and they're compensated for their time. Next slide. Currently, for this study, we're looking for adults who have stage 1, 2, or 3 breast cancer who are scheduled to begin chemotherapy at one of these UNC locations, and because of the limitations of the tests that we're using, speak English. And if folks are interested in learning more, they can contact me or my study coordinator, Yessi Lopez. Next slide. So this currently is a study where everyone who enrolls gets memantine, and we're looking at changes before and after chemo. But as we expand this research, we certainly would want to compare it to placebo to best understand its efficacy and then think about how it may relate to other cancers and other cancer treatments. Next slide. This is a nice figure from a review article actually looking at the cognitive effects of brain radiation, but I think that it applies to all sorts of parts of cognitive evaluation in folks with cancer. It certainly doesn't capture everything, but I do think it sums up a lot of what I've talked about today. So if someone's coming to you with cognitive problems, like with any problem, it's important to take a focused history and review of systems, think about what medications they're taking, particularly in brain tumors, but in other cancers too. Sometimes these cognitive problems can be an early sign of recurrence of cancer or progression of disease. You always want to check basic lab tests that may affect cognition, like vitamin B12 or folate deficiency, abnormalities in thyroid or cortisol levels, or testosterone deficiency. If nothing is coming up there, then that's where it's really critical to look at those comorbidities. Is your patient experiencing significant fatigue or depression, and if so, direct treatment that way. And then if that's not the case, or you do that and those things, get those things under better control and they're still experiencing cognitive problems, then you may want to consider what sort of cognitive problems are these? Are these more like problems with memory or more problems with like attention or concentration or focus? And you may need a specialist to help you understand that, because depending on the types of cognitive problems experienced, that may help guide you in what sorts of treatments, both medication-wise and behavioral-wise, might be most helpful. Next slide. There's a lot that all patients can do. I know that I see a lot of patients who like purchase activity books and like doing things like word searches, and certainly though that's not been studied in a really rigorous way in the research, I do believe those things can be helpful to patients, and I think if nothing else, it's giving them agency in what they're experiencing and allowing them to take a little bit of control back from a situation otherwise they may feel like they don't have a lot of control. Another thing like, word searches and related activities that folks can do is something called active journaling. And that's where you not just describe what you experienced that day, but to try to dig deep into why it was important, what its meaning was, what you learned from it, basically making your brain work in another way just by reflecting on everyday experiences. External aids can be extremely helpful. I mean, I think we all use things like planners, alerts, reminders to stay on top of things. And once you start to experience cognitive problems, those become even more critical. And people can be very effective just by optimizing how they use external aids. Everyday routine can be useful, going to bed at the same time, waking up at the same time, having other aspects that are the same from day to day can be very useful. If patients are either working or looking to return to work, I think it's important that people, have, real discussions with their employer, as well as look at opportunities with the EEOC to have certain workplace accommodations. And a lot of these people, have a lot to offer their workplace, and just because they may be experiencing some challenges in certain areas doesn't mean that they can't continue to really contribute to where they were working before. Next slide. This is a book that I read a few years back, and it's about 5 to 10 years old now. It's really directed for patients, but I find it to be very scientific, so I would recommend it either to all of you who are listening. It's relatively short. I think it's 90 pages and pretty easy to read, or your patients who are a little bit more scientifically minded. I do think it might be a little bit too complex or detailed for some patients, and so keep that in mind, but it's a very nice overview of both what this is and what treatments are available. And then final slide. Last thing I'll say is there really is few folks who are experts on what I've talked about, but we've highlighted here that there's a lot that can impact cognition, and a lot of those things are addressed through larger groups that pay attention to supportive care in cancer. And depending on where you're located, there may be, bigger or smaller programs that address this. This is the Comprehensive Cancer Support Program at UNC Chapel Hill. There's something similar and growing at Rex and UNC Hillsborough. But these are folks that can offer support from everything from mental health to nutrition to physical activity, a lot of things that really can be helpful in addressing folks' cognitive issues. And that's all I have for today. And thank you again for all your time, and look forward to, a few minutes here of remaining questions.
Dr. Nakamura, thank you so much. I would say you bowled a 300 game there, so that was excellent.
I've never done that in actual bowling, so I appreciate that.
Well, in your field, you certainly have, so thank you. Just a reminder, you can use Poll Everywhere now to go ahead and share your questions for Dr. Nakamura. While those are coming in, one that I've had and I wanted to understand better, you mentioned that for patients with cognitive impairment, that their providers were sometimes going to provide less aggressive treatments. Can you talk a little bit more about that, and any understanding of what the factors into that, and how that might affect ultimately the outcomes for the patient?
Yeah, I think in some ways that was a little bit of a surprising finding, that study, because what I think is a little bit more intuitive if someone's 95 years old and have already, lived a full, long life, the idea of exposing someone to treatment that's going to have side effects, even if it might prolong their lives further, it's understandable to think why that may not make sense for that patient. It also makes sense that someone who's, many 95-year-olds or folks who just otherwise are frail or very impaired, that they're less likely to do well with chemotherapy, more likely to have side effects, and that it may even have a negative impact not only on their quality of life, but their actual life expectancy. So again, it was a little bit interesting to see that cognitive impairment seemed to be even more, predictive of the treatment options that were offered to folks. And I guess I'll leave it there.
All right, thank you so much. Another question, this may not be related, but there are studies ongoing for the medication impact. Are there studies ongoing for the medication impact on stroke victims? Or maybe this is a different sort of brain injury. I feel like stroke patients are forgotten post-rehab.
Yeah, well, I'll say just up front that, treatments for cognitive abilities in folks who have been affected by stroke is outside my scope. I have really gotten pretty focused here on these issues in cancer patients. So I don't know the answer to your question. I can't even speak to, the part that you mentioned about being forgotten. But what I can tell you is that a lot of what we're starting to study in cancer-related cognitive issues is coming from other literature, including the stroke literature, and I mentioned traumatic brain injury literature. So a lot of this has been, we've benefited from research in these other areas.
All right, thank you. In your experience, are patients usually able to accurately perceive and evaluate their own cognitive impairment, i.e., can they tell you what specific deficits they've noted?
The short answer is no. And the other interesting thing that I've noticed is a couple things. One is that sometimes the people who have the most profound impairment on testing believe that they're doing great cognitively, that their impairment has actually gone beyond the point where they can really reliably evaluate their own cognition. And then the flip is true too, that there are a lot of folks who are actually still doing pretty well on testing, but they're noticing something that feels different to them and uncomfortable to them that, again, is just not able to be detected on testing. The other issue that I think comes up here is that most patients, and I think most people, just don't have the right words to describe what they're experiencing. So a lot of folks will rely on things that are often said in the day-to-day language, like I'm having a short-term memory problem, because they know it's not a long-term memory problem, but it might actually reflect another aspect of cognitive impairment.
All right, thank you. Next one, for patients with cognitive impairment, how did self-reporting compare in a group of 75 plus not undergoing chemo treatment?
Yeah, for that study that I shared, this self-reported cognition was not measured. And so that is definitely a push in the literature to dually evaluate both self-reported cognition as well as objectively measured cognition, and also to try to use similar measures so that we can compare findings between studies. Right now, it's really sort of a potpourri of research out there.
Thank you. And we'll just take one or two others, and then we do need to wrap up. What tools, treatments have shown success in improving cognitive patients 10 plus years out from treatment? Any studies at UNC for this class of patient?
And I guess I'll assume here that this is referring to cancer, folks who have had cancer. And for that, I would really direct you or your patients to the Get Real and Heal program. So that's, a physical activity intervention that's targeted at cancer survivors. And though that intervention specifically has not been rigorously studied for cognitive function, very similar interventions have. And so I think that is, a really great resource and thing to explore further here at UNC.
Great. And I'll mention to our listeners that we do have lectures from Dr. Bottiglini and Dr. Wood and Carly Bailey and others specifically addressing some of those issues. All right, last question. Are there cognitive impairment studies in middle-aged adults who are long-term survivors of childhood cancer?
Yeah, this is a really great question. So folks who are survivors of childhood cancer, this is a rapidly growing area of research. I mentioned kind of different vulnerabilities, and one I didn't mention in this lecture that was really focused on adults who get cancer as adults is that another vulnerability is to experience these insults while your brain is still developing. And so for many reasons, this population of people is thought to be particularly vulnerable. And yes, there are a number of ongoing studies, none here locally at UNC, but a number of ongoing studies to understand this better.
All right. Dr. Nakamura, thank you so much. This has been incredibly informative. I do want to also thank the University Cancer Research Fund, the generous support of the people of North Carolina through the North Carolina General Assembly, the UNC Lineberger Comprehensive Cancer Center, our team, Mary King, Veneranda Obore, John Powell, and Aaron Schmidt for all the work they do for this and every one of our lectures. We want to let you know that we've got oral complications associated with cancer therapy identification and practical approaches That's with Dr. Shazib, and that's coming up on July 21st at 4 p.m. That's our APP series. Then Thoracic Surgical Oncology with Dr. Modi that's on July 28th at noon. And then our next APP in August will be Gut Biome, Diet, and Cancer Immunotherapy with Jennifer Spring. So 3 great lectures coming up. Just again, a reminder, we will not be doing the R2P or PCC lectures in August, taking a little break there, and we'll come back full speed in September with some exciting topics. All right, just a couple of other things. Always more lectures coming into our learning portal, our new learning portal now. So we hope you'll visit there. If you haven't experienced these lectures live, go ahead and take them as self-paced online courses and let us know what your experience is like in the new portal. Speaking of letting us know, we've got a survey coming out in just a few weeks. This is our annual survey. We really want to encourage you to take a few minutes to respond to that, and that will help us inform our lectures in 2022. Can't believe we're talking about 2022, but we are, and we want to be planning ahead for that. All right, you know where to find us: Facebook, Twitter, YouTube, all sorts of places. Let us know how things are going, feedback on the new portal, questions, anything else. We'll look forward to seeing you later this month. Dr. Nakamura, thank you again. This has been really, really great.
Thanks to you, and thanks to everyone listening.
All right, take care. Thank you all for attending. We'll see you soon.